Good morning, Peter Goertz. I'm a psychiatrist. So courtesy in the doctor-patient relationship, sadly sometimes over the years, for example, when I worked on inpatient psychiatric wards, what I saw was that the very basic things were not done. Doctors would not say goodbye to patients when they left the hospital, when they were discharged. So I used to tell the medical students, if you do the very basic things, sometimes you're ahead of the game. If you shake the patient's hand when they come into the ward, if you shake their hand again and say goodbye when they leave the ward. So those are some basic things that can be very helpful already for the patient. I mean, you can have enormous medical knowledge, but if you don't do the basics, the doctor-patient relationship is going to be difficult to have as a positive relationship. So you're going to see different styles. If you see different doctors, it is probably unwise to say things like, I'm the doctor, I know what's best for you, I'm going to decide. Because the reality is, unless it's an emergency, if the patient's lying on the ground bleeding, that's an emergency, the doctor needs to take charge if it's a life-threatening emergency. But otherwise, if it's not an emergency, either psychiatric or medical, the patient's actually in charge, unless they're demented or otherwise totally unable to make decisions for themselves due to severe psychosis, for instance. But in general, the patients are in charge, barring an emergency. And you want to spend time with patients both on inpatient wards and outpatient, in outpatient settings, outpatient clinics. And that's easy to say because often you're not given a lot of time. You have a lot of patients to take care of, an enormous amount of paperwork. But it is important to do that, and otherwise you're not really going to enjoy your job probably if you don't have relationships with patients that are positive. And another thing in general is you want to be very careful giving prognoses because patients are very different. Some patients may not adhere to a plan, they may not take their medicines, and different people are just different, their bodies are different. So if you ever say something like, or it's probably a good idea never to say something like, you have 6 months to live, because that's maybe a statistical average, but each patient can be very different. And their prognosis, of course, can be very different. So courtesy is a basic tenet in a positive relationship between any human beings. And that includes the staff-patient relationship, the doctor-patient relationship. And we're all human, we all have our issues, that's for sure, and no one's better than the next person. And when I've said that, and obviously no one's better than patients, no matter how deteriorated they are, if they're homeless, if they're dirty, if they're sleeping on the street, if they're totally psychotic, no one's better than them as a human being. We're all just people with our own problems. And you want to communicate that to patients by your actions, but also you can do it verbally. And when I've said that verbally to patients, they've sometimes thanked me, and that kind of made me sad because that made me realize that often these people have felt inferior, and often that issue of feeling inferior was not addressed. So again, it can be very helpful if you shake hands when you meet a patient, if you shake hands when you say goodbye to a patient, for example, on inpatient wards, even in the clinic though, that can be helpful. Now, there are exceptions. If there's obvious dirt on the patient's hand, even feces I've seen, you don't want to do that. And also psychologically, if someone is very paranoid or on the verge of being assaultive, that's probably not the best time to shake someone's hand. Even though it's very interesting, an older psychiatrist on an inpatient ward where I worked used to actually go up to people who looked like they were about to explode and say, shake my hand. And that, I think, grounded them. But that takes a lot of courage because instead of shaking his hand, they could have hit him also. Those are very tense situations. So in general, if someone's on the verge of being assaulted, I would not recommend shaking their hand. But for this particular psychiatrist, it seemed to work. And if you're in a ward, like a psychiatric inpatient ward, you want to knock on the patient's door before you enter the patient's room. Just basic courtesy. Ask the patient, is it okay to talk right now? Just treat the patient like you would, hopefully, anybody else. It's a good idea not to have your hands in your pocket, not to chew gum while you're talking with the patient. And words also can make a difference, in my opinion. I know people often say client now instead of patient, or say healthcare provider instead of doctor, social worker, nurse, etc. But those newer terms that are used sound more like business to me instead of medicine. So to me, it seems more empathetic to use the older terms patient, doctor, social worker, etc., because they seem to me to be more focused on treatment and not on business/money, basically. Because unfortunately, medicine is often seen as a business and is a business, at least to an extent at this point. And when you meet a patient, if it's not clear right away, you want to ask them, how would you like to be addressed? If they say they want to be addressed by their first name, you have the option of asking them or giving them the opportunity or saying it's okay to address you by your first name. Again, you have to feel comfortable with that, but in general, it may be an option if you're addressing a patient by their first name to give them the opportunity to address you by your first name also. Because basically what we're talking about is inherently in the doctor-patient relationship, there is inequality because they're coming to you for treatment. So there already is inherent inequality. So there are differences in the levels where people are because you're the one they're coming to for treatment. So you want to minimize that though. And the way you address the patient, the way they address you can help minimize that. And you want to also make sure that your actions don't show that you feel you're on a higher level than the patient. So if you're sitting in an office talking to a patient, you want your chair to be you want the patient's chair to be just as comfortable as the chair you're sitting in. Because otherwise you can tell a patient, no matter how often you tell them, you're a good human being, no one's better than you. But if you're sitting in a much more comfortable chair, like you're sitting in an armchair and they're sitting in a stool during the visit, that your actions are saying something very different from what your words are saying. And in group settings, for instance, on a hospital ward, you don't want to have, if you're sitting in a circle, let's say 20 people sitting in a circle, you don't want to have one group of patients and then a separate group of staff in that circle. You want to have people intermingled, like one staff member, two patients, two staff members, one patient. So people mixed together, again, so you're not showing by your actions that you don't feel comfortable being next to a patient, which then tells them you may not feel that they're on the same level as you as a human being, which is just not true. So another issue can be beginning and ending sessions punctually. To me, that's important. Different doctors have different styles, so some people have a lot of difficulty being punctual, but that has worked well for me. And to me, it shows respect for the patient if you see them on time, and ending the session on time shows respect for the next patient because they're waiting for you and you don't want to start seeing them late. And it also provides structure in general for the patients you're seeing. If they know you're going to, in general at least, there always can be emergencies. But if the patient knows in general that you're going to see them on time and end the session on time, I think that's a good thing. And also then, since you're reliable, if they come late, there's no reason for you to extend the session, because you don't start sessions late. There's no reason they could feel justifiably to have the right to start sessions late and end them late, because you don't do that. Basic things, if on an inpatient ward, the patient's barefoot, doesn't have shoes, came in, off the street, just wearing no shoes or socks, you want to provide shoes or socks or both, hopefully, to the patient. If the patient has a physical problem, you want to examine them yourself as a psychiatrist or a doctor in general. And again, a basic thing, if they're thirsty, give them water. Things like that, some very basic things can improve the doctor-patient relationship. And if it's a psychiatric ward and patients who do not have clothing are given clothing, the clothing ideally should be of good quality, ideally of the same quality as the clothing the doctors are wearing. Because again, you want to have as little of a difference in equality or in status appearance as possible. And unfortunately, a lot of rooms nowadays on psychiatric wards do not necessarily have windows. And for instance, bathrooms, it would be nice if they had windows. Seclusion rooms, it would be nice if they had windows. So that may or may not be logistically possible, but it would be nice for the patients to feel respected. If you're locked in a seclusion room, you can't see nature at all. That, I'm sure, doesn't help agitation. And fresh air is another issue. In the past, people were locked on psychiatric wards, inpatient psychiatric wards, for days on end, maybe weeks on end, or months even. And they didn't necessarily have the ability to go outside, get some fresh air. So fresh air can be very helpful. Seeing nature can be very helpful. Again, I'm definitely aware there are logistical problems. We don't want patients eloping, but if there's any way to do it, fresh air, being in nature, exercising, all can be very helpful for patients and actually minimize the potential for agitation and most likely reduce the number of additional medicine, as needed medicine, they're going to need for agitation. Thank you very much.